All right, Christine, let's start tackling cardiac system pathologies. All right.
Yeah, let's tackle those cardiac systems.
So, first up, just kind of broadly speaking of all cardiac disease, some general signs and symptoms: AFib, really fast heart rate; cyanosis, that's that bluish tint; dyspnea, difficulty breathing; edema; fatigue; heart block, we'll talk about later; intermittent claudication, that's pain typically in the calf, brought on by activity but relieved by rest; different pains, palpitations, premature ventricular contractions; reduced ejection fraction, that's how much blood is being pushed out versus left behind. There should be some blood left behind, but if there's more and more, that's that reduced ejection fraction. That's not enough blood getting to the body because the heart contraction itself is weak. Syncope and ventricular fibrillation. So other signs and symptoms: a heart block. There's first, third, second, and third degree heart block. This has to do with the electrical impulses of the heart. So first degree heart block, electrical impulses are slow, but they don't interfere with those contractions. Again, no problem there. Second degree is the impulses are occasionally interrupted. And then third degree is impulses don't reach the ventricles, causing the heart to skip a beat. So if we're having that more and more, less and less blood flow being delivered to the body, and a whole bunch of problems that can happen to that. Intermittent claudication, pain with activity due to decreased blood flow. Again, it's not on page 91 in our textbooks. That's from a different textbook I was using. And pain specifically to the jaw, shoulder, and chest pain, especially if they're acute and severe, then at sign of a heart attack, we'll talk about later. Premature ventricular contractions, most common disorder seen on EKGs that we talked about earlier. Sometimes that can be normal after intaking of caffeine or smoking, maybe anxiety or alcohol consumption. Ejection fraction, we talked about briefly. That's the ratio between stroke volume and preload. So there should be some blood left in the heart, and that's going to help stretch the tissue to provide a strong contraction. And then the amount of blood ejected out versus left behind, normal is between 55 and 75%. The lower ejection fraction, the less blood being pumped, which means there's less blood supply delivered to the body, including the heart itself, which then is going to, if there's more blood left behind, it's going to stretch and distend that heart tissue, which is going to make it weaker and weaker over time. Which will reduce more power, and then the ejection fraction will get worse because of that. So this is a terrible problem to have because it feeds itself. It's a feed-forward problem. Syncope, lightheadedness, maybe even fainting when the brain has decreased oxygen, really important in the hypotension that we'll talk about later on. And VFib, complete loss of ventricular contraction, typically occurs with heart attack. So general treatment measures to look at is, first off, dietary modification, reducing your total fat intake, your intake of saturated fats, reduction of salt intake. The American Heart Association has current dietary guidelines, so if we needed to pull that up for our patient. One thing I will also say before we get too deep into this is someone with cardiac disorders has a team of people helping them, including PT, OT, massage, dietary nutritionists, cardiologists, primary care. It goes on and on and on. There's a lot of people that are going to be involved with the care of this team, or the team care of this patient. Generalized weight reduction program, regular exercise program. What the benefits of regular exercise is, improves overall cardiovascular function. So if we can improve the heart strength itself, that's going to only improve all of the function of the body. Lower lipid levels, increase in HDL lipoprotein levels. Again, that's that high density lipoprotein, good cholesterol, it's called. Reduce stress levels, smoking cessation. There's lots of drugs we're going to go over right now that can be used with cardiac disorders, so it can be overwhelming as we initially learn it. But lots of different drugs are available and being developed all the time. For our rehab medicine, the overall things we're going to do is improve endurance, decrease stress, educate, and potentially dip into our energy conservation techniques, breaking up tasks, making the tasks less intense. How can we do it seated, or do we have to do it standing? Things like that. You've talked about that in the past.
All right, cardiac medicines. So this table is a great example of a list of cardiac medications. We can see their use, their action, and the adverse effects. We're not going to go through every single one of them, but it is helpful to be familiar with especially the adverse effects when you are planning your treatment sessions with patients or clients and you're working with them, so that you know what you're looking for when you're working with them based on which medications they're on. So this is important information to be familiar with. So we're going to start with nitroglycerin. So the use is for angina attacks and as a prophylaxis to prevent attacks. The action is that it reduces the cardiac workload and peripheral and coronary artery vasodilator.
It's a very strong vasodilator.
And what's an example of how people use this?
We're going to look at this when we look at angina. This
Okay.
the number one mechanism, number one reason why we would use the nitroglycerin. We'll look at that in a little bit.
Okay, and this is something that sometimes people have special carriers to carry these pills with them on their keychains and things like that.
Absolutely. And if we're going to exercise with somebody and we see on their medication list, or exercise or perform manual treatments like massage, if they write down that they have nitroglycerin prescribed to them, they have to have it on them before we initiate any treatment of any kind.
Mm-hmm. And can we give it to them?
Patient can give it to themselves if they pass out, and then we can give that to them. It's an emergency situation, we can. But typically the patient would feel the symptoms coming on and take it themselves.
Mm-hmm. And so the adverse effects of taking the nitroglycerin can be dizziness or headache. So that's something that you would watch for if they needed to take that. Then metoprolol. So this is a medication that's used for hypertension, for angina, and it's an antiarrhythmic medication. So the way that it works is it blocks beta adrenergic receptors and it slows the heart rate. And because it's slowing the heart rate, it can lead to dizziness and fatigue. So this is a medication that if I'm doing a chart review to meet with a patient, maybe that I haven't met before, and I see that they were recently put on metoprolol, I'm going to remember that as I'm working with them, because there can be sometimes when people are first put on this medication, there's a period of time where their body's adjusting or the cardiologist is still figuring out what the right dose is for them. And so I've had patients who get really dizzy, who have a lot of difficulty participating in therapy as they're going through this adjustment period and have to take very special precautions with them. And some people can go on the medication and it isn't impacting their therapy as much, but it's definitely one that I've seen an impact.
Yeah, I think, for our students, I think the important things that they understand are the kind of grouping of adverse effects. I think when we look at these lists, there's a lot of repeats. Dizziness is all over the place. Fatigue is all over the place. And the last three have a lot of bleeding problems. We'll look at that in a second. So for our students to understand the adverse effects, and then we can be part of the healthcare team and say, we've missed 3 out of the last 5 rehab visits because of dizziness. Or if they're on these medications and you're getting a patient up off of a table, like in massage is going to happen all the time with, or even with all of the rest of our treatments, to be aware of that and not just turn your back as the patient's getting up. No, keep your eyes with them. Make sure that they're not dizzy as they're standing. So I think the important ones, nitroglycerin, Digoxin is an important one. The diuretics for furosemide, also known as Lasix, and then the blood thinning ones, warfarin, we talked about in a different lecture, and aspirin. Those are the big ones that we should have a working knowledge with, but really it's the adverse effects in general that you should be recognizing.
And so you see these medications and you'll want to take their blood pressure maybe more frequently. Be aware of having, so it's more, how are you keeping them safe from these adverse effects while you're working with them? So having them change their position more slowly, checking in with them on any symptoms that they're feeling. The next one I want to talk about quickly is Lasix. So this is another one that can lead to some challenges. It's a very important medication. It addresses edema with congestive heart failure and also addresses hypertension. It's a diuretic. So what it does is it increases the secretion of water and sodium. And when that increased secretion of water and sodium means increased urination. And this can lead to challenges with medication compliance with patients.
Yeah.
Because they don't want to have to keep getting up and going to the bathroom. Or maybe they're starting to have some difficulties with incontinence, and that is something that can be difficult for them to have to face. And so being aware of them being on this medication, they can have nausea, diarrhea, dizziness, also the increased urination. So one example I have of a patient with Lasix where it really impacted his functional ability is he wanted to be able to go to a movie every Wednesday with his nephew. And he wasn't able to do that because he had to use the bathroom so frequently. And he was using a rollator to get up and have to move around to go to the bathroom multiple times during one movie. And so this was something that was very important to him, a meaningful activity in his life. And so I was able to communicate this with his physician, and all they had to do was change the timing of administration of the medication, and he was now able to participate in this meaningful occupation. So just like Josh said, being aware of the adverse effects and how that might impact intervention.
Coronary artery disease, also known as ischemic heart disease or acute coronary syndrome, includes different conditions like angina or myocardial infarction. So this is the overall condition, and then you can have other serious conditions like heart attack that is led to because of this. So coronary artery disease is the leading cause of death in the United States. Roughly 27.6 million people are living in the United States with coronary artery disease. Men tend to develop symptoms earlier in age, while women tend to have more complications due to CAD. So the first CAD conditions we'll talk about is angina.
So angina pectoris, so the pathophysiology is it's chest pain that occurs when the heart muscle demand for oxygen is greater than the supply available. So the heart is needing more oxygen than is available to it. Limited blood supply can be because of the inability of the coronary arteries to dilate or because of partial obstruction by atherosclerosis. So the etiology is atherosclerosis, arteriosclerosis, vasospasm, myocardial hypertrophy, which is the heart muscle being too big for the available supply. Severe anemias and respiratory disease can also cause the oxygen deficit. And then some activities can trigger increased cardiac demand for blood, and that can include running up the stairs, shoveling snow, getting angry, having a respiratory infection, being exposed to cold weather extremes, pollution, and eating a large meal. And so sometimes working in a subacute rehab, when the census is low and we know that there's a snowstorm coming, we know that we're going to be getting patients who are shoveling snow, and this is what's happening and why they're coming to us.
Yeah, and actually, my grandfather, when he was still around, he had angina from shoveling the snow. And what's frustrating for patients is they go through an activity like shoveling snow, have chest pain. The chest pain, the symptoms we'll look at next slide, mimic heart attack, call 911. By the time that the rescue gets there, symptoms may have resolved. And if they haven't resolved, then by the time the ambulance gets to the hospital, symptoms have probably resolved. So then they're sitting in the hospital saying, but I don't feel it anymore. I want to go home. But we've still got to investigate this and then treat it more.
So signs and symptoms and treatment of angina. So it's recurrent, intermittent, brief episodes of substernal chest pain. It's typically triggered by physical exertion or emotional stress. Pain can be described as tightness or pressure in the chest. It can radiate to the neck, to the jaw, or the left arm. And other physical signs can be pallor, diaphoresis, and nausea. What's diaphoresis?
Excessive sweating.
Okay.
Not going to trip me up on that one, Chris.
So these episodes typically last seconds to minutes and often relieved by rest. So the treatment is the patient can be prescribed coronary vasodilators like nitroglycerin. We mentioned about nitroglycerin. If chest pain persists after taking medication, the person might have to seek hospital care to rule out myocardial infarction or heart attack. And then education on avoiding triggers, so cold or hot weather, understanding fatigue, use of RPE, rate of perceived exertion, or dyspnea scales, and then a strong emotional incidence. So anti-anxiety medications and stress reduction techniques can also be recommended. And then in rehab medicine, it can be a part of a closely monitored exercise program. And then having a patient with a past medical history of angina is important to exercise only if vasodilators like the nitroglycerin is on hand, which Josh mentioned. And then in terms of rehab medicine as well, with occupational therapy, it is within our scope to work on the stress reduction techniques, can be a part of intervention that we can provide.
Next up, myocardial infarction, also known as a heart attack, we're involving death of the myocardial tissue. So the angina, symptoms resolved after rest. Now with myocardial infarction, there is tissue death. It's heart tissue death. So for people who survive a heart attack, there's greater risk of a second heart attack, also congestive heart failure or stroke occurring within the short time. Heart attack MIs, it should be a capital MI. MIs are classified based on the ECG findings. ST elevation MIs, non-ST elevation MIs. There's 5 different types based on their cause. Type 1, blockage of a major artery due to atherosclerosis. Type 2, mismatch of oxygen supply and demand. Type 3 only involves fatal heart attacks, and types 4 and 5 are due to other things like other medical procedures like angioplasty and stents. So what we would be seeing is types 1s and 2s. I don't think any of us are going to be seeing type 3s anytime soon. Type 1 MIs can develop in one of 3 ways: thrombus buildup, which obstructs the artery; a vasospasm that occurs in the artery, so that quick contraction of the artery causes the blockage of blood supply, or part of a thrombus, typically from the lower extremity, typically a DVT, a small piece of the DVT breaks off, floats into the smaller arteries of the heart, and lodges itself, blocking the smaller coronary artery. So at the point of obstruction, any blood supply that's needed distal to that obstruction, the heart tissue becomes necrotic, it dies. An area around the injury develops inflammation and ischemia. Specific enzymes are released from the myocardium into the blood. So that's one of the ways we diagnosed heart attacks as well, is looking at the blood enzyme levels. If blood supply can be restored within 20 to 30 minutes, irreversible damage can be avoided. So there is a short window that we get to save this heart tissue. The better the collateral circulation of the arteries, that will reduce the size of the injury, the how much tissue is involved. If the blood supply is not returned, the heart tissue will eventually become fibrotic, and that fibrotic tissue is not going to move well. That if that heart tissue does not move well, it doesn't eject blood well, and that can create the congestive heart failure that we'll talk about a little later. So typical signs and symptoms, first obvious one is pain. Sudden substernal chest pain radiates into the left face, jaw, arm, described as severe, steady, crushing type pain. Pallor, diaphoresis, nausea, dizziness and weakness, anxiety and fear. One of my favorite signs of a heart attack is denial of a heart attack too. That's part of that anxiety and fear. Hypotension with a weak pulse that is rapid and a low-grade fever may happen as well. Important note that there are silent heart attacks where our patients can have prolonged subscapular or shoulder pain. Historically, that happens more in women than in men. And sometimes the only symptom can be gastric discomfort, indigestion, heartburn. So there are these silent heart attacks that are out there where somebody will go to their docs because they've had unrelieving shoulder pain, and doc sends them to either PT or OT to work on their shoulder pain. And it's important to understand that. Diagnostic tests we've talked about a little bit: ECGs, blood enzymes, arterial blood gases, pulmonary artery pressure measurements. Really, the blood enzymes and the ECGs tell us the most. So complications of heart attack: sudden death after MI occurs in roughly 25% of cases. That's pretty high, typically due to the cardiac dysrhythmia. Cocaine users may suffer from fatal heart attacks due to the drug interfering with cardiac conduction, as well as causing severe vasospasm, and then that vasospasm causes occlusion. Then cardiogenic shock can occur if the pumping ability of the left ventricle is severely impaired. Congestive heart failure is a common after a heart attack. This can occur days or years after heart attack. Has to do with the heart tissue becoming fibrotic and no longer able to contract to eject blood. We'll talk about congestive heart failure in a little bit. We'll see why that is. Less frequent complications occur: rupture of the necrotic heart tissue. Typically, this happens 3 to 7 days post heart attack. And thromboembolism may result from a thrombus that develops over the infarcted tissue inside the surface of the heart. If it originates in the left side of the heart, because the left side of the heart ejects its blood to the rest of the body, this is a big danger for now a different piece of different piece of this clot to lodge into somewhere else. Brain is of particular concern. So treatment, well, initially life-saving treatments: medications, oxygen, keeping the patient calm, pain relief, anticoagulants. Might require external shock to reduce the dysrhythmia. Surgeries can be performed: CABG, coronary artery bypass graft, to get around the blockage is a common one. And the patient might also be prescribed a low-dose aspirin for the blood thinning effects of it to prevent future heart attacks. For rehab medicine, well, the formal cardiac rehabilitation includes inpatient, outpatient, and maintenance phases, and there's specific exercise prescriptions for each phase that we are following closely. And the patient is monitored closely on the inpatient and outpatient phases, and then self-monitored in the maintenance phase. Other individualized plans include dietary modifications and stress reduction techniques. Schedule for returning for normal activities are established. So those activities include climbing stairs, return to work, resuming sexual activities, all things that we should be talking to our patients about and not afraid to talk to them about, because it is important aspects of their life and things that we want to get back to. Also, we should be aware of heart attacks as past medical history as well. So sometimes we see people right after heart attacks. We're part of that inpatient or outpatient team. But a lot of times we'll have patients that have had heart attacks 3, 5, 7 years ago, and they'll be our patients now for different problems. So we should be aware of them. That way we get to monitor them a little bit closer, especially if they're here for a total knee replacement, but they had a heart attack 8 years ago. Well, having them on a stationary bike is a great exercise for after a knee replacement. However, someone who had a heart attack 7 years ago, we need to monitor them a little extra closely. The prognosis depends on size and location of the infarction. Mortality rate for the first year is between 30 and 40%. So it is a serious, serious condition. As serious as a heart attack, they say. Different cardiac dysrhythmias. So now we're talking about the electrical system of the heart. Deviation from normal cardiac rate may result from the damage of the heart's conduction system itself. SA node, AV node, bundle of His, left and right, bundle branches, Purkinje fibers. That's that neurological conduction system of the heart. It can also be because of different electrolyte imbalances, fever, hypoxia, stress, infection, or drug toxicity. So dysrhythmias reduce the efficiency of the heart's contracting, of that pumping cycle. A rapid heart rate prevents adequate filling, which will then reduce cardiac output. So again, too fast of a heart rate, we're not getting enough blood actually ejected out. And slow heart rate will reduce the blood to the tissues because we're not ejecting enough blood out either. That includes brain and heart conditions. I think heart might be missing over a letter there. So different types of cardiac dysrhythmias and what their conduction change and effect is. Bradycardia, slow, regular rate, but it is slower than 60 beats per minute. So it's still regular rhythm, but the rate is slower. So stroke volume increase, possibly reduction in cardiac output. We have tachycardia. Tachy means fast. That's the regular rhythm, but faster rate. 100 beats to 160 beats per minute is what that would be defined as. Atrial flutter, even higher, 160 beats per minute to 350 beats per minute. My goodness. So what's happening, especially with these atrial flutters and then fibrillations, we'll talk about next, rate of greater than 300 beats per minute, is that there's very little filling time. Basically, there's the heart is squeezing so fast that the blood is never filling the heart to then be ejected in the first place. It's just so frenetic. We're not actually moving the blood at that point. We could have premature ventricular contractions, bundle branch blocks, heart blocks we talked about a little bit. The other one I want to spend a little bit more time on are the total heart blocks, where there's no conduction in the AV node. So the ventricles will slowly contract independent of the atrial contraction. So that's complete uncoordination of the heart. There's no, the normal lub dub is atrials contract, then ventricles contract to eject the blood that you need. Now that there's no sequencing of it all, it's just all mismatch and there's no efficiency there. That is going to cause a decrease in output and likely cause syncope. So the big ones we want to have our students understand are bradycardia, tachycardia, atrial flutter, and fibrillation. Those are the big ones that we want to talk about. So the treatment of cardiac dysrhythmias, medications, and looking at the side effects of medications are important, like Christine, you had talked about earlier. Digitalis was one of those medications. Digitalis toxicity is really common. Various AV blocks, PVCs, bradycardia, and ventricular tachycardia. Beta blockers, which are prescribed for arrhythmias, can also cause bradycardia, and diuretics can cause a potassium imbalance. Antiarrhythmic drugs are effective in many cases, but some people might require a pacemaker. So that's a surgical implant that they get to, now the pacemaker controls the rhythm of the heart. For rehab medicine, being aware of pacemakers is really important because it's a contraindication for a lot of different modalities that we use. We also, one quick note that I would say for dysrhythmias, when we use a pulse ox type of measurement for our heart readings, for our heart rate readings, they are really unreliable because they don't calculate the dysrhythmia as well. So having our manual reading is really important. If our patient has history of dysrhythmia, make sure we're doing manual reading of our heart rate and not relying on other machines to do so. Probably my favorite disorder to talk about is congestive heart failure. The pathophysiology of the congestive heart failure, CHF, occurs when the heart is unable to pump sufficient blood to meet the needs of the body, usually as a complication of other condition like a heart attack, but might be because of valve disorder or a combination of other factors. Chronic condition, but we can have acute episodes within it. So you might have congestive heart failure, that's your diagnosis. And after you eat a salty meal, you might have an acute episode where now all of a sudden the heart is that taxed even more. So initially, various compensations maintain the cardiac output, but these compensations will eventually aggravate the condition. So reduced blood flow to the kidneys causes an increase in renin and aldosterone secretion. Those secretions will increase vasoconstriction, will increase the blood volume in the heart after contraction. As the blood volume stays in the heart after contraction, it's going to cause this stretching and dilation of the heart itself, which makes it harder to pump the blood. If it's harder to pump the blood, we're going to reduce blood flow to the kidneys. The kidneys sensing that will increase more renin and aldosterone secretion, which causes more vasoconstriction, which causes more blood volume in the heart. And it's just this feed forward cycle. And especially over years of having this, it can cause the problem to become worse and worse and worse. So two main effects from when the heart can't maintain its pumping ability. The cardiac output decreases, so there's less blood supply to the body. That's the big thing. The other thing is the backup congestion in the ventricle behind the affected ventricle. So there's left-sided heart failure and right-sided heart failure. There's other newer names for it: ejection preserving heart failure, ejection fraction reducing heart failure. I'm not as familiar with those terms. I think of it nice and simply as left and right heart failure. So the left side of the heart, if we go back to our anatomy and physiology review, the left side of the heart receives its blood from the lungs. So if the left side of the heart is weak and not ejecting its blood to the next phase, it's going to have a backup into the lungs. So left-sided heart failure will cause pulmonary congestion, fatigue, weakness, dyspnea, cold intolerance, versus right-sided heart failure called cor pulmonale. Again, I use those terms interchangeably, cor pulmonale versus right-sided heart failure. What that's going to do is that's going to have backup congestion. Where does the right side of the heart get its blood from? Well, the body. So it's going to cause congestion, systemic congestion, typically edema in the lower extremities and abdomen, fatigue, weakness, dyspnea, cold intolerance as well. So signs and symptoms, infarction that impairs pumping ability, the efficiency of this is the etiology, efficiency of the conduction system, different valve changes. So we could have congestive heart failure because of valve changes as well, or congenital heart defects. Coronary artery disease is the #1 cause of congestive heart failure, and pulmonary disease can then cause right-sided heart failure as well. So signs and symptoms can be subtle initially, but then become more and more marked as the disease progresses. Each side of the heart will cause effects of decreased blood supply to the tissues and hypoxia, fatigue and weakness, dyspnea, especially with exertion, cold and exercise intolerance, and dizziness. Again, if it's left side only, we're also going to see things like dyspnea, orthopnea, maybe proximal nocturnal dyspnea, which is you can see that often sleeping with the head of the bed elevated or in the recliner. And in the home care setting, when I see my patients, I often see a mountain of pillows that they're sleeping with their heads up, or the patient hasn't slept in bed in years. They always sleep in the recliner to relieve just pressure from their lungs. But also the cough is another hallmark sign of the left-sided heart failure. Right-sided heart failure, the hallmark signs are the dependent edema, lower extremities, buttocks if seated. That is the #1 sign that we see with right-sided heart failure. Could have digestive disturbances when there's edema in the digestive tract. Acute increase in pressure in the superior vena cava might cause a flushed face, distended neck veins, headache. That can require prompt treatment to prevent brain damage. So here's a little picture of right-sided versus left-sided heart failure. You can see the big thing, right-sided heart failure. Look at the size of these legs. That's the dependent edema. This sign also says right-sided heart failure, weight gain. When somebody has congestive heart failure, we ask them to weigh themselves every single day. Same time, wearing the same amount of clothing every single day, because weight gain of I think it's 3 pounds or more in a week would be a call to the doc to get on medication to decrease the amount of edema they're holding on to. Christine, which drug do you think would be most commonly prescribed for someone who has heart failure and retains a lot of water?
Well, with all that edema, we're going to get all that water out of them. So it would be the diuretic, and that
Yeah,
one was the
exactly. The
Lasix.
diuretics. So, and then with calls to docs, we can call them, and that is always a medication that needs to be changed with someone with heart failure. If it's too much diuretic and they're becoming dehydrated, they're at risk for falls because they're dehydrated. If there's not enough, they're gaining more and more weight. So we ask the patients to weigh themselves every single day. That's really important. So treat the underlying cause if you can. Reduce the workload of the heart, reduce stress, reduce fatigue, energy conservation techniques, prophylactic measures like flu shots, or looking at other respiratory conditions like the pneumonia vax is important. Diet with low sodium intake, because wherever salt goes, water will follow. So if your intake in salt is high, you're going to keep retaining more and more water, which more and more water increases the load of the heart, the workload of the heart. Adequate protein, iron, and levels, and fluids. And man, that is such a battle when our patients are on diuretics. They don't want to drink any fluids because then they have to go pee all the time. And especially if they're afraid of falling or they're in pain and they don't want to get out of their chair to go walk those, 45 feet to the bathroom. That is such a battle with all of our patients with congestive heart failure, making sure they intake enough water where they're not becoming dehydrated, but not taking in too much. Medications to reduce blood volume, like we just talked about, the diuretics. Maybe different anxiety medications to reduce the vasoconstriction and decrease blood pressure. with rehab medicines, avoiding massage strokes that would overload the heart. So if we're doing massage strokes that increase the venous return, increase fluid return to the heart, well, if the heart can't work through that increase in workload, we are damaging them even more. Energy conservation techniques, functional endurance, and gait and potentially assisted device training are important. Valve disorders are pretty easy to think of, right? So the valve prevents backflow. If we have a valve disorder, then we're going to allow backflow of fluid, of blood. Most commonly in the aortic and pulmonary valves. Valve issues can be categorized as stenosis, which is going to restrict blood flow going forward, or incompetence, which means the valve doesn't close completely and it allows a backflow of fluid. That's the regurgitate of fluid backwards. If we have valvular deficits, it will reduce the efficiency of the heart, reduce blood stroke volume, and relies on compensations. With stenosis, the increased contraction force is going to be to force more blood flow through the narrow opening. So if you have a stenotic valve, the force of the contraction is the body's going to increase that just to push more blood through the narrow opening. This will eventually lead to hypertrophy and eventually it'll fail. It also can be a problem for things like angina or even heart attack. If that heart tissue keeps growing and growing and growing, do we have enough adequate blood supply to feed that hypertrophy of heart muscle? If we have incompetence, the compensations for that, well, the heart must increase its efforts to maintain cardiac output. That's the number one is probably going to be to increase the heart rate for that. Treatments, surgical valve replacement. You can have a mechanical valve or an animal valve. Bovine is the most common one. Pig valves, those are fun. Or there are tissue engineered valves as well. If you could choose, Christine, what do you think? Would you choose mechanical valve, animal? What do you think?
Oh, I've never really thought about it. I think, I don't know.
I'm going pig.
Yeah, that's where I was leaning to.
Yep.
I think I'd have to do more research to make
I would go pig, and I would hope that some of the pig creature powers would be also implanted. Like maybe I could find truffles really easily.
Yeah, there you go.
It might be.
Yeah.
So valve replacements can last up to 10 years, but they are susceptible to thrombus formation. So patients after these surgical valve replacements are required to take daily aspirin. The ASA is the abbreviation for that, to reduce that thrombus formation. For rehab medicine, being aware of the bruising and bleeding risk due to the blood thinning medications like aspirin. So watching out for our hands-on techniques, massage techniques. Patients are going to be much more susceptible to bruising and bleeds with that. So here's some pictures of the stenosis in the first picture here. Not enough blood flow getting into the way because that's so narrow. The regurgitation is, the blood flow entered the ventricle. However, it's when the ventricle contracts, it's just going to push back into the atrium as well. Here's a picture of the mechanical valve, tissue valve, and this is the bovine, I think. Or that might be the engineered one. Should just picture. What's your favorite pig to think about?
My favorite pig to think about?
Yeah, there's plenty to pick from. Miss Piggy. We got the pig named Babe.
I thought you meant what type of a pig. Like I would love to have a little pet piggy.
Yeah, a little potbelly pig.
Yeah, but I would like to have the kind that when you buy one, you think it's a potbelly, and then you're like, why is this thing 300 pounds?
Yeah, definitely.
I want a giant one.
Yeah. Christine, you want to talk about high blood pressure?
Yeah, finally. I like to say something. I'm like your emotional support colleague. So we we had a little battle over who gets to do CHF, and you won
Yep.
because it's your favorite.
And I
So-
have a lot to say about pigs, so I got to win the
Yeah,
valve.
so you're welcome, everyone. So hypertension, it's high blood pressure and is a common issue, both primary and secondary hypertension. So about 1/3 of adults has hypertension, and 1/3 of these people are undiagnosed and some are not controlled. So men are more likely to have hypertension when they're over 55 years old, and women are more likely to develop hypertension after menopause. Some more epidemiological info is African Americans have a higher prevalence of hypertension. And then some of these can be related to some of the dietary habits and wellness practices as well, depending on what people have available to them. So socioeconomic status can also impact this. Pathophysiology is there's an insidious onset, and it often goes undiagnosed until complications arise. And that's why it can be called the silent killer. So there are 3 major categories of hypertension. The first is primary or essential hypertension, and it's idiopathic, and it's categorized at 140/90 millimeters of mercury. And what we'll focus on in this class is mainly the primary or essential hypertension. Then there's secondary hypertension, and that results from renal or an endocrine disease. And then malignant or resistant hypertension. So a hypertensive emergency with extremely high blood pressure, and that typically results in organ damage. So essential hypertension, there is an increase in arteriolar vasoconstriction, and it increases peripheral resistance and reduces the blood supply to the kidneys. So that increases the renin and angiotensin and aldosterone secretions. So that can further increase the blood pressure. And then over a long period of time, the increased pressure leads to damage to arterial walls. And then this damage can cause narrowing, tearing, aneurysm, or it can encourage atheroma formation, and that can lead to PVD and CAD. So the etiology and signs and symptoms. So again, hypertension is idiopathic, but there are many contributing factors. So we talked about some of these: age, genetic factors, familial trends, lifestyle characteristics, high sodium intake, excessive alcohol intake, and prolonged or recurrent stress. So there's a lot of areas here where patient education can be an intervention, especially from an occupational therapy perspective. Signs and symptoms. So this can be asymptomatic in the early stages, and then there can be vague, non-specific signs, and that can include fatigue, malaise, morning headache, constantly high blood pressure under a variety of conditions, and then complications can also be asymptomatic until they're well advanced.
I will say just quickly, no one measurement would diagnose somebody with high blood pressure. So that category, that diagnosis of 140/90, well, it's no one measurement. So if you only have a high blood pressure once, because blood pressure constantly changes depending on time of day or the situation we're under, it needs to be measured. It's routinely above that number. It's not just, oh, you measured high today, here's your diagnosis.
Mhm. Okay, so let's see. So lifestyle changes, again, reduction in salt intake, reduced body weight, stress reduction, and generally improved cardiovascular fitness. And then medications can be mild diuretics, ACE inhibitors, and other antihypertensive agents. And then patient compliance can be difficult because they aren't seeing obvious signs of an illness being present. And then side effects of the medications can be more obvious than the signs of the hypertension. Plus, if what we want is for people to make lifestyle changes that can be difficult to incorporate, they're not seeing these obvious signs of an illness, it may not be enough to motivate them to make the changes. So compliance can be challenging. Rehabilitative medicine, so education, lots of education. Improve patient compliance, so look at ways to how to motivate them. And you could be the first person to examine the blood pressure for the patient. So always make sure that you're communicating when you're recognizing these signs and symptoms and documenting and reporting them. And then there is a risk of orthostatic hypotension, which we'll be talking about if on certain medications that are used to treat hypertension. Orthostatic hypotension. So this is a sudden drop in blood pressure, and it can occur with a change in position. And it's typically from supine to stand. So the etiology is that the poor blood pressure control can be due to venous valve impairment or baroreceptor impairments. Change in position can cause gravity to push the blood to the lower extremities, and the poor blood pressure control causes the symptoms. It can, as we said in the last slide for hypertension, this can also be caused by medication changes that were used to treat hypertension, and the treatment kind of takes it too far, the wrong direction. Signs and symptoms, so brief symptoms after positional changes, and that includes lightheadedness or dizziness, blurry vision, weakness, fainting or syncope, and confusion. And then medical treatment is making medication changes. As we mentioned, sometimes cardiac medicines have to go through a period of adjustment based on how the body's responding. And then changes to hypertension medication dosage or other medications to limit blood pressure drop. And rehabilitative medicine, so what we're looking at doing is encouraging proper hydration. We want to break transfers into segments, allowing breaks in between, and teaching patients how to check in and look for signs and symptoms if their blood pressure is low of these positional changes leading to the orthostatic hypotension. So teaching them to move slowly and check in with themselves. Do I have any of these signs and symptoms before I make my next move in this transfer? Possibly ankle pump exercises prior to the transfer. And then proper guarding is always important when you have orthostatic hypotension.
Yeah, so easy just to say, okay, get up out of this table. I'm going to turn around and, throw these towels away or whatever it might be. But that's when our patient's going to fall. So always proper guarding with your patient and, maintaining proper guarding. So really important.
And it can be helpful to do an orthostatic blood pressure too, when you're trying to get a sense of when you are doing these position changes. So I'll work with a patient, and when they're supine in bed, take their blood pressure, then have them sit up and see the change when they sit up, then have them stand and see how much it changes, and then sit and check it again. That helps you to be more informed so that you can keep them safe.
Definitely. And, it's typically happens when we go from supine to stand, which we do in our rehab medicine all the time. All three of our disciplines will do that all the time. But it can happen sit to stand. It can happen supine to sit. So it can happen in the smaller transfers as well. So, yeah, really good. All right, Christine, that was it for us for this topic.
Great.
So we'll maybe the next discussion post we'll ask our students to write their favorite pig character. We got the three little pigs we could talk about. We got what's Charlotte's Web. Charlotte had a best friend that was a pig.
Yeah.
So yeah, maybe that's what the next thing will be.
That sounds like an important part of the education.
Yeah, that's right. All right, Christine, until next time, I hope you have a wonderful day.
You too. Bye, everyone.